The aim of this podcast is to help you have a better path to parenthood and a better parenting experience. So every week, I try to give you information that will help you in that vein. But sometimes people wonder, why should I listen to this information? Why is this more helpful than the person who tells me to eat 6 pineapples or this information that I saw on the news? Well, today I'm going to answer that question with Dr. Ginsburg, and she is the current president of the American Society for Reproductive Medicine, and she will tell you why it's important to listen to some information over other information and how you can help yourself on your path to parenthood. So take a listen. Welcome to Building Your Family. This is a podcast about fertility treatment, donor conception, surrogacy, and all the ways the modern family is built. My name is Lisa Schumann. I'm your host, and I'm so glad to introduce you today to Dr. Ginsburg. Dr. Ginsburg is a past medical director of the Assisted Reproductive Technologies program at Brigham and Women's Hospital in Boston, Massachusetts. She's a clinical expert and educator in the field of assisted reproductive technology. She also used to chair the Art Ethics Committee, which we're going to talk about, and I will talk about all the exciting things that she's doing now. Dr. Ginsburg also consulted at the Dana-Farber Cancer Institute, where she became passionate about improving fertility in people with cancer. She also established the first organized clinical program to freeze eggs and embryos for women undergoing cancer treatment. She later worked to educate and collaborate with health insurance companies toward covering egg and embryo freezing for women with cancer. And Dr. Ginsburg developed the only program in Massachusetts for freezing ovarian tissue for children and women with aggressive cancer diagnoses. She's also an author, a editor-in-chief of a new medical journal, an administrator, and now the president of the American Society for Reproductive Medicine. So that is all a mouthful, but suffice it to say, Dr. Ginsburg is amazing and has done so many wonderful things with her career. And as you know, last year we had Dr. Paula Amato on talking about new technologies in our field. And now I think both socially and politically, we're facing so many new challenges. And so I'm so grateful to have Dr. Ginsburg here to talk to us about the ethics. Since she is a specialist in ethics and heads the ASRM now, she does have a lot of challenges, but is certainly well equipped to handle anything that comes her way, I'm sure. And so I'm so grateful she's here and so happy to share her wisdom with you. So welcome, Dr. Ginsburg. Thank you for coming.
Oh, it's my pleasure. Thank you for inviting me.
So why don't we start a little bit today with explaining to the audience what it means to work on the ethics committee, what it is to develop ethics for the American Society for Reproductive Medicine, and why that matters so much to patients.
Firstly, we have a multidisciplinary group. It's composed of reproductive endocrinologists, so those are physicians who are subspecialty trained in fertility care. It's a specialty that with 3 years of training after the OBGYN residency. It includes ethicists, so people with advanced degrees in medical ethics, generally at least one attorney, and generally other people from other disciplines. So we try to get a pretty broad input.
Mm-hmm.
We try to have people who've been patients and have used fertility treatment to try to get very broad perspective on the ethical issues that do come up in the course of our careers, and also to answer questions that lay people or the media might have when they're thinking about reproductive care. That's how the group is organized. We have very long discussions about ethical topics. Usually somebody in the organization will say, gee, I have a question that a patient came to me with. Oftentimes that is what generates a topic on a specific ethical issue. So, for example, one of the things we were talking about earlier is the conflict between patient autonomy and physician autonomy, meaning when a patient wants to do a particular treatment, but the physician isn't comfortable providing that treatment, who should win? Sometimes patients do end up in a situation where multiple clinicians aren't comfortable providing a particular treatment they want to do. They end up shopping around till they find somebody who's willing to do it. And is that in the patient's best interest? So there's an interchange between also the practice committee at the ASRM, which is a group of, again, clinicians in different subspecialties that come up. They review the literature really carefully. So all of the documents have to do with the appropriate medical care in a given situation in patients with certain kinds of infertility. For example, the appropriate evaluation and treatment for male factor infertility. And so the ethics committee looks to the clinical guidelines, what is appropriate medical treatment, what we know from studies works and doesn't work, and we use that to try to phrase, how at least practicing clinicians should think about medical treatment. So, for example, one of the things we talk about and the practice committee talks about is when is treatment appropriate and not. And generally we came up with, the practice committee came up with the thought that if a treatment has less than a 5% chance, for example, a cycle of IVF has less than a 5% chance of resulting in a birth for that particular patient or couple, we shouldn't be recommending that treatment. Doesn't mean you can't do it as a clinician. You can discuss with the patient, make sure a patient's clear on what her likelihood or his likelihood or their likelihood of having a baby is, but make sure they're clear before the treatment starts. We consider treatment futile if there's considered to be less than a 1% chance of success based on particular patient's characteristics. And there's a lot of literature, particularly in IVF, and we're reasonably good at predicting outcomes. For an individual patient, obviously, it's a 0% or 100%. You either have a baby or you don't. And many patients are sure they're going to be in the 1%. And so can sometimes see the clinician as somebody who's standing in the way of their ability to have a baby. So it gets very tricky. For example, some women may have really significant comorbidities or other medical conditions that makes pregnancy really dangerous for them. They may be in a situation where they're unwilling to or can't have somebody else carry a pregnancy for them. And so there can be a conflict between what a physician thinks is appropriate and what the patient really wants for herself. And those are they're really tricky to navigate.
Yes. It's so tricky. And also, I think it's so hard for patients to understand. Sometimes patients will say, well, if I got pregnant at home, then nobody's going to tell me at 55 I shouldn't have a baby. But you're also asking a physician to be involved in that, right? And so that's a whole different story.
Exactly. I think one of the things, and this is very tricky and a very sensitive area, is the treatment of women with high weight. So we do know that if women are significantly overweight or underweight, the chance of having a baby is about 30% lower if someone is in a quote unquote obese category of weight. And the higher the weight, the lower the live birth rate. The American College of OBGYN even has a statement saying you need to be able to provide appropriate care, but if you can safely take care of a patient, you shouldn't refuse to just because their weight is high. And so, especially in the area of IVF, there's an enormous difference between in the weight cutoffs that different programs have, and sometimes it is a safety issue. If a program's in a freestanding surgical center, they don't have access to emergency care. If there's an airway problem with the patient, they're not anywhere near a place where they could do a blood transfusion. They have to limit the sort of degree of difficulty of the patients they take care of. And sometimes patients really feel very wounded if they connect with the physician, they get to the point where they need IVF and they're told really they can't provide the care there. Ideally, what our ethics committee and practice guidelines say is that the clinician's obligated to send them to a program that would be able to provide the care or at least do the counseling, more extensive counseling about it. So that's a very tricky situation. And in some ways, the availability of the GLP-1 agonist medications, these weight loss drugs, which work very effectively, make it even more complicated because some of these patients might actually be able to lose substantial amounts of weight, but it's very hard to get these medications approved. There's a shortage of most of them. They're extremely expensive out of pocket. So this is a particularly sensitive and I think ethically tricky area because there are some people that need these medications for help control diabetes, not just because they want to get to a body mass index threshold where the local IVF practice would accept them. So it's tough.
It's very tough. And I think people also, and maybe you can speak to this as well. I worked in some egg freezing research when ASRM still had egg freezing on the experimental
Mhm.
list. And it took some time before egg freezing was taken off the experimental list. And patients don't often think about that. They think that people in reproductive medicine practice kind of willy nilly, but it actually takes a long time for ASRM to approve something.
Exactly right. And that has to do with there being enough published peer review reports, meaning that we know that the data presented in a paper is actually true and valid, so that we can tell patients what the likelihood of having a baby is. And much of this country still, fertility treatments are out of pocket. And so if a patient thinks that she has a 90% chance of having a baby with a particular treatment, but in reality, in her situation, it's 10%, she needs to know that before that money gets paid.
Yes.
And with egg freezing early on, the reports were so disparate. Frankly, from an egg freezing standpoint, the survival rates of eggs vary a lot batch to batch. Even now, we're seeing a lot of eggs from egg banks for women using them for donor eggs. And on average, the survival
Mhm.
is probably 85% of eggs surviving, but there's a huge range. And we don't see that huge range with embryo freezing where the survival rates are well over 95%. So it's still, I wouldn't say it's early, but it's still not as well established as something like IVF and embryo cryopreservation, which has been around for, many years.
I would imagine that most of the technologies, ASRM looks at very carefully before they decide, yes, this should be taken off the experimental list, which kind of gives a signal to the physicians and then to the patients that we really need to proceed with caution.
Right. And when we have something on an experimental list, it usually has to do with the fact that we can't really quote a pregnancy rate. We're not really sure what the long term complication rates are. And from something that's going to result in the birth of a child, making sure that there's no evidence of a higher risk of birth defects or other poor outcomes. So that's the tricky element there. And those are the kinds of things that we pay attention to.
Yes, and I think for all of you out there that are listening to this is very important to understand that everyone is really looking out for your best interest. And no one's trying to prevent patients from doing things kind of willy-nilly. These are all ideas that the ASRM works very hard at trying to think through thoroughly to make sure that everyone is protected. And I think that's a really difficult situation for us both politically and socially. So could we talk a little bit about that, Dr. Ginsburg, and about how ASRM can really let the public know? Because there is so much, I guess we could start with the political part. There's so much noise out there, and certainly this was a contentious election. But no matter what side you're on, I think the average person has a lot of confusion about what to believe and how to understand what's right and what isn't. And when you look at the political system, you want to believe the political system. And of course, we want to, but if they're not taking the word of ASRM, which are the experts in developing these criteria, what do we do as an organization?
Yes, it's very tricky. ASRM has very clear stance on, for example, personhood bills,
Hmm.
which are popping up in many state legislatures. Personhood bills, sort of at the basis of it, they typically state that an egg, once fertilized, is the same as a person.
Yes.
And in the context of creating embryos in IVF, unfortunately, the vast majority of embryos are never destined to create a baby. So if
Right.
you were in a situation where you could only fertilize one egg at a time, a program could be accused, and this is what happened in Alabama.
Hmm.
Programs had to shut down because they know when they thaw an embryo, it may not survive. Not every embryo will grow well enough to be reasonable to transfer into a patient, or has an abnormal fertilization and would result in probably not a miscarriage, or if that, and they were in a situation where they couldn't provide care without potentially being accused of manslaughter or murder. And so the disconnect between the reality of IVF treatment and what we know works and what state legislatures who know nothing about the science have decided based on kind of personal beliefs about what life is really in conflict. So in Alabama, what happened was Obviously, patients were very upset. Cycles were stopped in the middle. Programs felt they were forced to close.
Yes.
And the state government, put in a law basically protecting IVF practice. There are still other states that have these types of very restrictive bills kind of hovering. And obviously, we don't believe that a person is a person until they're a person and they're
Mm-hmm.
born.
Right.
So that's been the ASRM stance. And I think the stance of the vast majority of the population, when surveys have been done, the vast majority of the population in the United States supports IVF treatment as it's practiced.
Yes. But we're still kind of in a situation, even, with vaccines, that there's going to probably be some debate, right? And so medicine, I think in general, is going to be under fire by the political system. And so how do we get the word out to the public that ASRM, and I'm sure ACOG and every other group, works so hard to make sure that all of these issues are thought through and the patient's best interest is taken into consideration in every, as you mentioned, legally, emotionally, medically, in every which way. And yet all of this could be wiped out in 2 seconds by, some legislation that isn't based upon any medical data.
Right. And I think that's the tricky thing. All of the professional guidelines and practice guidelines, meaning what's appropriate medical care for a particular situation, are based on published data. We consider this objective data. There have been studies showing for sure that a particular treatment will have a particular outcome. When people have a belief, you can't necessarily argue with a belief because beliefs aren't fact-based. Whether you believe that Darwin's theory of evolution is the case or people were placed on the planet by God, I would say that Darwin's theory has been proven by scientific evidence. We don't have evidence of God at all. And when people have a belief that's like a belief in God, but it sort of leaks over into belief in a particular medical treatment, that's really concerning. Because if somebody decides that they have a belief that vaccines are bad when we know they save lives, and there are lots of studies showing that, it's really concerning. And there's anecdotal evidence for anything. Can somebody have a reaction to a flu vaccine? I once got a flu vaccine and a temperature 104. That usually doesn't happen. Yes, a one-off can happen, but that shouldn't change somebody's perspective based on one anecdotal experience. And so what we were discussing before has to do with the fact that now that there's online access, anybody can say anything. And just because somebody has a platform online doesn't mean what they're saying is actually scientifically valid. And
Yes.
that's the concern we have about patients getting information from unreliable sources.
No matter how much we know or that we've seen and research over and over that, the flu vaccine is not going to cause autism in your child, even though we know that, people still believe that. And so, what do we do as an organization, from, let's say, from the ASRM's standpoint or any medical organization to try and help people really think and vote and act in their own best interest, right? Because their faith or their belief is kind of acting not in their best interest very often.
That's an excellent question. I wish I had an answer for how do we change somebody's belief in something that's not evidence-based to trust of something that is evidence-based. And I don't know where that trust disconnect I don't really know what it comes from. It's very hard for me to understand why someone might believe in something that's posted online by a non-medical person, non-scientific person, but
Mhm.
not believe a professional organization statement that's based on years and years of research and lots of people who are very smart and who have a lot of experience in an area putting forth, the best medical practice guidelines. I'm confused by that, honestly. Do you have some insight into where that comes from? I really don't.
I think there's so much emotion behind some of these experiences because we have seen a rise in this sort of behavior or experience recently, right? And so there's a lot of emotion behind it. And it is difficult, I would imagine, for ASRM as a group to be able to kind of swim upstream here and try to help people when there is all this false information out there, particularly as you mentioned on social media, where, we see people talking about, well, if you eat 4 pineapples, then you'll get pregnant, or you can rejuvenate your eggs. And I think there's a lot of anxiety for patients, understandably, and a lot of misunderstanding, which is getting better, about reproductive aging. I think it's a very tough pill for a lot of women to
Mm-hmm.
swallow. And I appreciate that it's hard to accept. And so when you're desperate, you want to try anything. And I completely appreciate that. But it does leave the door open for some groups to prey on vulnerable people by offering snake oil instead of IVF treatment. And people want to believe it. And that's a really tough thing. And so I'm so glad that you're here for this reason, because I think it's really important for people to understand how hard people like you work every single day to help to craft these guidelines, and work very hard to understand so many aspects of a patient's experience to try to help them have the best journey possible. And everyone wants these patients to get pregnant. Imagine your beautiful future. You're snuggling with your child. You feel so connected to them. Your friends and family are so happy, and you have everything that you've ever wanted. I want this for you too, but I want more than that. I want you to feel secure knowing that you've made the best decisions, not just short term, but long term, for your future family. Wherever you are on your journey, whether you're choosing a donor, choosing a clinic, learning how to talk to your donor-conceived child about their origins, all of these decisions will have wider implications for your future. And I want you to have the right resources so you can feel empowered and confident at this very important time in your life. That's why I'm so excited to introduce you to Building Your Family. It's the only expert-guided platform designed for parents and parents-to-be using reproductive medicine. We provide unique strategies that you won't find anywhere else to make your path to parenthood smoother and more informed. And that's why our approach is about offering practical and actionable steps that you can use right now. Whether you're just starting out or already deep into your process, Building Your Family is here to guide you with expert advice, specialized education, stress reduction strategies, and a community to support you every step of the way. We can't wait to see you inside. What are some of the other things that ASRM does? I know they've become more involved this year in really trying to kind of ramp up their political presence and get involved in some of these discussions.
Yes, and we're partnering with American College of OBGYN and other sort of interested organizations in making sure that we're aware of bills that are being proposed in different states. Resolve, which is a national organization really composed of individuals who are very invested in fertility treatment, mostly patients or partners of patients that have done fertility treatment, having them active in those states and actually telling their stories at state departments when these bills come up for votes is incredibly important. And so ASRM is doing all they can to help support them, giving resources. Again, we've enlarged our public relations staff, our office, to make sure that we have enough people that can keep tabs on what's happening in these various governmental offices. So that's what we're doing from the standpoint of trying to make sure that non-evidence-based information isn't pervading at least discussions about what's going to happen in a state legally, because some of these states are going to potentially have there could be the possibility of IVF being illegal in particular states, and that would be disastrous, obviously, for the people that go there. So it's already hard enough to undergo IVF treatment, but to have to travel out of state to do it would be, impossible for some people. And again, most of the country does not have coverage for IVF. The other thing that the ASRM has been doing in partnering with Resolve is really lobbying to put proposed bills in state houses to increase insurance mandates to cover. So, for example, this year, California covered a mandate to cover infertility treatment, and it doesn't include very small organizations. If an organization has more than, I think it's 50 employees, that the health care that employer offers to their employees has to include IVF coverage. And there are some carve-outs as well, but In general, expanding coverage for IVF treatment is one of the things that I think is most important to the ASRM. It's probably not in our, financial best interest of members to a certain extent. You would make less money per treatment when it's insurance covered, but we think it's the right thing to do for
Yes,
patients.
that's wonderful.
That's been something else that ASRM has really been working on. We also have more of a presence on social media than we used to. They have a team just looking and making sure our Instagram is updated, making sure there are links to different podcasts and things that go through that sort of appropriately cover infertility treatments or other things related to reproductive health. So those are just some of the things that have been in the works, this past year anyway.
That's so important and wonderful because, as all of you out there know, IVF is so important to so many people. And even if we do have some acceptance in the coming years for some fertility treatments in some states, there are other ways, and we talked to Barb Calora recently about this, also about how there could be other restrictions that we may not see as, you're talking about, embryos and what do we do with them. And certainly I think in the area of third-party reproduction, ASRM recently changed their language around what it means to have infertility. And we really have to accept that many IVF patients are not going to be cisgender couples, right? And many people who watch this podcast are not. And so we really need to also remember that we're not just talking about IVF as maybe some political experience people feel is important between a man and a woman going through infertility treatment, but also for all people, single people, people in the queer community. So those rights will automatically be respected and protected as you support ASRM and as you support, some of these really important initiatives.
I think you're absolutely right. The other thing ASRM has been active in forever. We're really trying to also increase the focus because we're in part an educational organization. Practice guidelines were established to educate care providers, but really they're a reference for anyone. They're accessible to anyone who wants to read them, but also helping to improve the care of patients getting reproductive care internationally. So partnering with international organizations, improving their continuing medical education for their care providers is very important. We're really lucky in the US in that fertility treatment and fertility training, so reproductive endocrinology fellowships, are long-standing in the US. Other countries, it's been a little bit watch what I'm doing, and then you can open up your own IVF practice.
Wow.
And so other countries are starting to establish more structured fertility programs, and we're in the process of more codifying exactly what's involved and what needs to be involved in the training, partly so that other countries can use that to be able to train really high quality care providers. In the US, we have boards, so there are specialty exams that we have to do in order to get board certified. So it's very clear what level of competence you need to become a reproductive endocrinologist. And again, in other countries, it's a little bit of
I don't have that.
I can just hang up a shingle if I feel like it situation.
That's difficult. Yeah. Well, that's wonderful. Something else that I thought might be interesting for the listeners to hear that ASRM is also involved in as you are doing all of these things, you're also looking at new technologies and some new things that are coming down the pike. So maybe you can share a little bit about that, Dr. Ginsburg, because I think people would be eager to hear about that as well.
There's been interest in things like in vitro maturation of eggs for many, many years. Probably back in the 80s, there were case series that were published of women with a condition called polycystic ovary syndrome, where they don't really ovulate regularly, sometimes also would need IVF, where they could have eggs extracted, matured in culture, and then actually have eggs fertilized and create embryos without going through as much stimulation, as much of the fertility hormones as that we normally use in the course of an IVF cycle. And there are companies now that are working on trying to sort of structure that in a more kind of business-like way.
So it's systematic.
It's a more systematic way. One of the things that we really are hoping is that ovarian tissue will be a source of eggs that can be used in IVF. So far, all but one pregnancy from ovarian tissue has caused pregnancies by having that tissue replaced in the person. So in a patient with cancer who's having tissue replaced, you got to be very sure that there aren't cancer cells in that tissue that you're going to be putting back in that person after they've finally been cured of their cancer treatment. So we're really hoping for technology to improve to the point where we don't have to ever put that tissue back in a person. We can get these very, very immature eggs from the tissue to mature in culture systems, fertilize in a culture system, and have just an embryo where we don't have any concerns about transmission of cancer back into that person or a gestational carrier. So that there's a
That's
lot of
fantastic.
interest in that area right now. The other area where we're seeing more and more publications, and this is going to be important probably 20 years from now, is in vitro gametogenesis, meaning making eggs. So far, most of the data are making eggs out of other body cells. We know this can be done in mice. One of my colleagues actually published a paper last year showing that he could get other sort of ovarian cells when they're treated with various proteins to go ahead and become eggs. He could make baby mice from those eggs. The baby mice that were born from those eggs were able to procreate normally. So
and they were two male mice, right?
It's certainly proof that it's doable. The tricky thing is that mice only live 2 years. So we don't know, and the mice that were born appear to be healthy. Hopefully people live into their 80s. So we don't know that the same technology, which does include the use of viral DNA in the process of transforming these cells to become eggs rather than just a skin cell or whatever else, it's going to be a long time before we can make sure that that's safe and isn't going to cause, downstream medical problems for children and adults who create it that way. So that's another area of interest that I think there's a lot of research on right now, but I don't think it's ready for prime time.
I'd love to hear more. I just want to mention to everyone who's listening that the way this is going to translate for you, and another reason to be so supportive of ASRM, is to really think about what would happen if you don't need as many drugs to go through an IVF cycle. How much more pleasant would your cycle be? How much less expensive would the cycle be? And if you're using an egg donor, what about her, right? She doesn't have to go through all of those difficulties in her cycle. She doesn't have to worry about the cramping. She doesn't have to travel for as long, and it may be less expensive for her as well. So there's a lot there. With every one of these developments, there's so many benefits for the patients, and certainly the gametogenesis has the opportunity to potentially give same-sex couples a baby, right? And lots of other things. So there's so many things on the horizon that are so helpful for everybody out there. It's really important to stay on top of and support the research. I know it's an emotional trigger when you see something on the media that makes you feel upset and makes you want to kind of look away from these things and think about what's in your heart. But it's also good to balance that with some of the practical aspects of these treatments, because these treatments are really there to improve all of our lives.
Right. And it's do no harm too. So the other thing is we don't want a case report to generate a whole practice performing whatever the treatment is when we don't really know what the long-term outcome is. So it is really important that these investigational things be done under investigational umbrellas, meaning there's a research committee, usually in a hospital situation, that's overseeing the research, making sure it's being done ethically, making sure any people that are being involved in the research are informed that it's research, that we don't know what the chances of success are, what the potential risks aren't necessarily known, et cetera. Really critical.
And so that way we really know if we're saying that something works, we really have had experience and we know it's safe, because yes, it's important to get through these treatments, but you want to be safe. You want your children to be healthy, because although it's natural to feel like I just want to get pregnant tomorrow, and I understand that experience, it's also important to think about the long term. This baby will be a grown up person one day, and you want to make sure that this person is healthy.
Right.
So what else do we have to look forward to?
Oh, the other thing that's certainly very prevalent in the medical literature right now is the use of artificial intelligence to inform medical decision making.
Hmm.
So, an example would be typically what's happening in the situation where we're determining what medication protocol, for example, might be best for a couple with low sperm count and blocked fallopian tubes, or low sperm count and endometriosis. These AI companies are getting access to hundreds of thousands of patients worth of data, or cycles worth of data, and we're hoping that with appropriate programming, we'll be able to tailor what treatment is going to be best for that particular couple. Because right now, it is really a little bit of a gestalt thing. We look at a
Hmm.
woman's ovarian reserve, whether she has a high, medium, or low number of eggs, to a certain extent, making sure she's not at risk of having, complications from high estrogen levels, for example, when we choose a stimulation protocol. But we really don't know exactly what dose of medication is going to be right until we see how she's responding. We're hoping that these large AI studies give some more clarity to that. So far, I haven't seen anything that I think is really revolutionizing the practice. But I think with more data, and also as these algorithms improve, we may be able to sort of tailor the particular treatment to the particular person undergoing the treatment. Artificial
Fantastic.
intelligence also, from the standpoint of the IVF laboratory, is, I think, going to move along more quickly. For example, time-lapse imaging is commonly used now in IVF laboratories. That's where a computer actually watches an egg fertilize. There's a video of it, watches an embryo grow. And as more research comes out, again, you have to analyze the data scientifically. As more research comes out, it does look like certain characteristics of early embryo development are very good at predicting blastocyst development. That's the sort of advanced stage of embryo development, at which point, if that embryo is placed in the uterus, it has the highest chance of success. So predicting, we can't make an embryo necessarily make a blastocyst by doing anything specific to it,
Hmm.
but at least these AI algorithms do look like they're very good at predicting blastocyst development. And so does that mean potentially embryos won't have to be taken out of the incubator as often to be assessed? It could be that they could just be inseminated and then just looked at X number of days later, because you can be looking at the videos of how they develop later on. So it may actually sort of decrease staff time in the lab, but also help improve selection of embryos for embryo transfer. There are some papers coming out suggesting that that can be really helpful.
That's so exciting.
One of the other sort of industry sounding things is barcoding for patients. And you can't barcode an embryo, obviously, but barcoding the dishes and the other containers that embryos are in, to make sure that there's less likelihood of mislabeling, using barcoding, and of course, computer
Mm.
systems to be able to track embryos. That's increasing in availability. So I do think that's going to be, within the next 5 years, probably many practices are going to be moving to that. Right now, the standard is still dishes are hand labeled,
Mm.
and so then there's more of a risk of inadvertently switching numbers or something like that. I should
Hmm.
point out, though, that ASRM and also the guidelines that scientific accreditation organizations use, require that there's two separate individual identifiers on every dish containing an egg or an embryo or sperm. So the likelihood of a mix-up is actually extraordinarily low even without barcoding, but I do think that will really improve efficacy.
That's fantastic. And so I think that it's really important to kind of highlight that not only are we looking at efficiency right in the lab, like you're saying, which is tremendous, but for the patients, that also might mean that they have fewer transfers, that there's less chance of feeling like this cycle has failed and the sadness and depression that comes with that, and maybe even miscarriage.
Right. No, exactly. And we're not at the point, I don't think, where we can look at an embryo and determine miscarriage. Oh, the other thing, and you were asking about advances, there's also a lot of research looking at non invasive ways of determining the chromosome complement of embryos. So, right now, if an embryo is going to be assessed for chromosome normality, pre implantation genetic testing for aneuploidy is the term that's used. The embryo has to have usually around the embryo has to have a hole made in its outer coating, usually with a laser, 5 cells of the outer coating of the embryo pulled out, the embryo then frozen, and then it takes often 2 or 3 weeks to get the results back from the testing lab to find out which embryo tests as normal versus abnormal. There are lots of studies being done looking at the DNA that the embryo actually extrudes into culture media as it develops to see if there's a non-invasive way of doing that. So that's still in the works. I'm hopeful within the next 10 years we won't be biopsying any embryos anymore. But again, the studies aren't enough to say that it's even equivalent to embryo biopsy.
I think that'll be music to the ears of a lot of people, both scientists who are very excited about that, but also people who of faith who don't
Mhm.
like any manipulation with their embryos. They'll have one less thing to worry about.
Right. And again, the question, and I don't want to get too much into the weeds, is when we do biopsy embryos these days, most of the time we get a clean result, but about 15% of embryos will come back with what's called a mosaic result, which means some of the cells tell us that the embryo is normal. Some of the cells tell us that the embryo has extra or missing chromosomes. And so that mosaic embryo is a little bit of a dilemma. We often are transferring these anyway. The other thing that we are running into, and we're not sure if the non-invasive testing will be better, is that about 10% of embryos that are biopsied, the cells don't actually give a clean enough DNA result that the company is willing to report normal or abnormal. And those embryos have to end up going through another thaw and biopsy and refreeze, et cetera. So it is hopeful that less invasive technology may, mitigate some of those funny results.
That's great because then we don't have to look at like a pass or fail system in the same way, right?
Correct.
That's fantastic. Well, those are amazing, amazing ideas. And I hope that they'll all come to fruition in the very near future because I think patients need continual encouragement that there is this hope and path to parenthood that they want. And hopefully also good information will continue to be disseminated. And I really appreciate all you do to help advance that cause, Dr. Ginsburg, because we really need people like you to help us on this path. We need it now more than we've ever needed it, I think, in my history anyway. And so thank you so much for everything you do. As we close down, do you have any other thoughts or things that you'd like to share with the audience?
I think for anybody in the audience that's a patient, I think, please be willing to ask questions. Your physician's there not just to tell you what to do, but to make sure you understand it. I always think that when I meet with a patient, I'm trying to educate him, her, or they to make sure they understand why I'm making the recommendations I am, or understand what condition they have that we think is preventing them from becoming pregnant. So I think asking questions is really, really important. I'm always really sad if I see a patient for a second opinion who wasn't clear on what was going on in previous treatment. And I think, some patients really have trepidation about asking their doctors questions. Feel free to. We don't expect you to have any knowledge coming
Mm.
into the office. So I really encourage patients to advocate for themselves.
That's wonderful. Well, thank you for that. I'm sure everybody will appreciate hearing that because I think for many patients, they're overwhelmed, anxious, and also intimidated by the whole process. Most people don't remember their 10th grade biology course, so they feel completely overwhelmed when they start,
Right.
right? So I really appreciate that. And is there some way that people can reach out to you, or should they reach out to ASRM if they have questions?
I think ASRM is a reasonable way to go. ASRM actually has quite a good website that's geared for patients called reproductivefacts.org. And it really does, without a ton of medical jargon, spell out a lot of the treatments we do, reasons for them, clarify some diagnoses. I don't mind people emailing me. People find my email all the time. It's eginsburg at bwh.harvard.edu. So feel
Right.
free. It's really been a pleasure. This was fun. Thank you.
Oh, well, thank you so much for coming on. I really appreciate it. I know you're super busy with all of these jobs. You have multiple jobs. It's amazing. And I appreciate all you do. And thank you, all of you, for coming today. I appreciate your time as well. Wherever you are, have hope. There's lots of support out there for you, like Dr. Ginsburg and the American Society for Reproductive Medicine, to give you factual information and really help you along your path to parenthood, because we want all of you to achieve your dreams. So thank you for coming, and please hit subscribe, because that's how we keep going. And I will see you next week.
Thank you very much, and have a good day, everyone. Bye-bye.
Hi, it's Lisa Schumann. I hope that you enjoyed that video, and I hope it helped you. And if it did, please give us a thumbs up and subscribe, because that's how we keep going. It's really important to us. And if you liked it, you might like this one.